بسم الله الرحمن الرحيم. إن شاء الله السيشن هنتكلم على الهارت فيلير. الكلام اللي احنا بنتكلمه طول النهار هنختصره دلوقتي في هارت فيلير with preserved ejection fraction. البرزنتيشن الفيرست برزنتيشن بروفيسور أبينا زكي شيفا من كازاخستان. Talk will be on revolution in treatment of heart failure with preserved ejection fraction. Please.
Thank you so much. Thank you very much, dear chairpersons, and it's my very great pleasure to be here with you. But actually, when I was given this talk on the revolution in HFpEF, I just was thinking that actually what is happening right now, it's almost a revolution. So your session and your conference, it's a revolution, not only in the HFpEF, but also just in overall in heart failure. And I was just thinking, what is exactly, so this is my disclosure, and I'm sorry. So I was thinking, what is really can be revolutionary in HFpEF? So I decided just, I will try to make it very too easy because it's a very difficult topic from my perspective, but still. And I decided to go to the definition of a revolution. So the revolution is a Latin and meaning a turn around. But actually the first is not very common to us. So we're not trying to have another government or a social order. So it's better if we will think that it's a dramatic and wide-reaching change in the way something works or is organized or in people's idea about it. So that is very good for heart failure with preserved ejection fraction. And why? Because why it was really needed revolution? Because first, this is a get with a guidelines heart failure registry, and actually the number of patients is very, very meaningful. And they started to gather data from 2005 to 2010. And what they've seen that the number of patients with HFpEF was increased from 33% to 39%. At the same time, the patients with reduced ejection fractions was decreased from 52 to 47. And actually, once again, they just make a trajectory, and they've seen that in 2020, the number of patients with ejection fractions over 50 will be more than 50%. And moreover, about 65% of total hospitalizations will be exactly related to HFpEF in 2020. Another thing, and exactly it's repeating the data from the previous registry, it's an optimized heart failure registry. And this data shows, once again, if we will see on a left and the right side, so actually about 30 to 50% of total hospitalization will exactly be related to HFpEF. And that is the first revolution, what made in a HFpEF. It was a definition. And this definition was first presented in a heart failure guidelines in 2016, but 2021, once again, they repeated that. It's very important that we have to define heart failure by phenotypes. And HFpEF with symptoms and signs, its ejection fractions above 50, and we do need objective evidence of cardiac, structural, and functional abnormalities, as well as raised natriuretic peptides. Well, we understand that if we're talking about symptoms and signs, they are common across the whole spectrum, and it's dedicated to HFrEF and HFpEF, except with S3 sound and cardiomegaly that is more common for patients with HFrEF compared to HFpEF. But we have to also, we know that actually patients with the HFrEF have highest all-cause mortality. Well, it's true from the EC heart failure long-term registry, but if we will say that patients were hospitalized due to worsening of heart failure, and that is very nice study that was published in JACC in 2017 that showed that despite patient will have a HFpEF or HFrEF, it doesn't matter. Actually, the mortality, readmission, combined cardiovascular readmission and heart failure readmission was quite the same for reduced and preserved ejection fraction. Why that difference is? Probably because they were hospitalized due to the worsening of heart failure. And that is data from Paragon heart failure study that showed that if patient has signs and symptoms more than 3, their prognosis and their prognosis and burden will be higher compared to patients that have actually less than 2 signs and symptoms. Why I'm taking that into account? Because actually it's going for that one reason. Before we saw that heart failure with preserved ejection fraction, it's just a concentric hypertrophy or restrictive cardiomyopathy with diastolic dysfunction. But actually, it's if we know the risk factors that really it's confounders for HFpEF, we have to understand that there are also other confounders that really causing HFpEF and really go into go into heart failure with preserved ejection fraction. It's diastolic dysfunction, it's a pulmonary hypertension or abnormal vascular resistance. We can say about systolic function despite preserved ejection fraction, impaired peripheral oxygen utilization, left ventricle systolic and diastolic functional reserve, and chronotropic incompetence and stiffness. So we have to understand that it's a multi-phase of heart failure with preserved ejection fraction. That is why probably we have a different outcomes in different pathways for these patients. So we are not taking that it's a common mechanism. It can be a different mechanism, but well, still. That is why we do need the second revolution. And the second revolution was first presented in 2019 when the HFA-PEF diagnostic algorithm was presented by heart failure. And that is position statement that you already know about. So if we do have a risk factors like advanced age, obesity, metabolic syndrome, or diabetes, physical inactivity, arterial hypertension, atrial fibrillation, ECG abnormalities, and elevated natriuretic peptides. So there is a very nice algorithm. So we do need to have initial work, then a diagnostic workup, advanced workup, and etiological workup. So I would like to step on to these first points. So we do think that it's we have at least one of the at the initial work at the baseline. So we do need to go to the to the second step. And this step is showing us that we do have either major or minor criteria. And according to this criteria, we can identify HFpEF itself, or we can think to go further in identification, like a diastolic stress test or invasive hemodynamic measurements. But actually, that's very good and very relevant to identifying a HFpEF in our patients. So that is really very revolutionary. But if you would just go back to 2012, well, that was in a guideline, so no treatment has yet been shown convincingly to reduce morbidity and mortality in patients with HFpEF. And that was actually true not only for 2012 guidelines, but also 2016 guidelines. It was the same, absolutely the same. No treatment has yet been shown convincingly to reduce morbidity and mortality in patients with HFpEF. What was challenging and why it was like that? There were several attempts to show the beneficial effect. We saw that in charm-preserved program, there was no difference between placebo and candesertan. About PEP-CHF trial, there was no significant difference. It was, perindopril, I-preserved with irbesartan, the same. Top cut study, it's a little bit different kind of study, but actually I would like to stop at this study a little bit later, but still that was the reason why we didn't have any changes in the guidelines since 2012 to 2016. And now that is a revolution number 3. And I would like to start again with a top cut study. We all know that top cut study, it was that was a spironolactone in HFpEF patients compared to placebo. And if you would see the number of patients is 3,445, and patients with ejection fractions over 45 for a median follow-up 3.3 years. Yes, we didn't, the primary endpoint that was published in New England journals didn't show significant difference. And that is true. But when they've made analysis, and actually they've done it very well, they have seen, and it was published 2 years later, that actually that is not so true. And that was heterogeneous between the continents. And that so for America and Canada, that was positive study. and no data, no significant difference for Russian and Georgia. And probably that was true because the patients that were included in Russia and Georgia were not HFpEF. That's why we really were needed two revolutions. We were needed a definition, and we were needed a very nice identification of heart failure with preserved ejection fraction. So that is one of the reasons. The second, in 2018, but I think that the next speaker will talk about that, that was also very important because that is also dedicated some impact on in patients with HFpEF, because amyloidosis is also a patient with heart failure preserved ejection fraction. So tafamidis showed a good result compared to placebo in reduction of primary endpoints. So it's a mortality and hospitalization, and we can see it on that Kaplan-Meier curves. But also, what I would like to show you the next, it's you already discussed this trial, the Paragon trial. You discussed that in a meeting that was it really good for HFpEF patients or not, but I would like to give you some insight of this study. So Paragon heart failure study was actually involved 43 countries with 848 sites. And we can see that there are really, a worldwide program for heart failure with preserved ejection fraction patients. So what Paragon heart failure treatment showed? Yes, there was they missed the primary endpoint. And actually that's true, but the thing is, if we can see first, reason why they missed that, they compared sacubitril valsartan with an active comparator, so with valsartan. That is one of the reasons why. Probably there was some kind of a discussion about that. One of third or maybe less, there were patients with amyloidosis or hypertrophic cardiomyopathy. Probably that was also the reason. But when they made a sub-analysis of this study, they really saw that, and it already was discussed today, that there was heterogeneity, significant heterogeneity by sex and ejection fraction. So that was very good for female, that worked very well, and that worked very well for patients with ejection fractions at or below median 57%. And well, I would like just to give some kind of an answer to one of the questions: should we or should we not? So FDA really approved use of sacubitril valsartan for exactly these two indications. It was indicated by FDA that you can use, United States can use sacubitril valsartan for patients with ejection fractions below normal range, below median 57%. So the second is, and it also already was said today about SGLT2 inhibitors, that is data from empagliflozin in heart failure with preserved ejection fraction. And I would like to say, that's why I mentioned here that SGLT2 inhibitors, one treatment for all HFpEF patients. And that is true because if we can see here, no matter what kind of ejection fraction it was, maybe a little bit tricky for patients above 60%, but still, we had a very good result in empagliflozin arm compared to placebo. So, and moreover, we've seen that the early effect with empagliflozin was on the 13 days, on the 16 days with empagliflozin compared to placebo. And that result was not just was achieved, but it was maintained during the whole study of EMPER preserved. Another thing, what is also good, and that was already mentioned about the liver study that was presented during EC 2022. So dapagliflozin in heart failure with mildly reduced or preserved ejection fraction also reached its primary endpoint, and it was really true for primary composite outcome, and they've made it not only a hospitalization for heart failure, but also for an urgent reason for heart failure and cardiovascular death. Secondary outcome, and that is also very nice, that recent study started to include the KCCQ and so this, the questionnaires for quality of life, because FDA also approved quality of life questionnaires as an endpoint for heart failure studies. And it was really safety for patients with heart failure and preserved ejection fractions. But one more thing that was in the liver study, they were not including only patients with preserved ejection fraction, but they also include patients with improved ejection fraction. So that is one of the studies that really include them, because actually before this study, other trials actually excluded patients with improved ejection fractions, what is probably maybe not so right. And the early effect was like, well, it doubled effect of empagliflozin, because with dapagliflozin, the early effect was also have seen, and that was true, I think, this 13 days of description of dapagliflozin compared to placebo. And once again, it maintained through the whole treatment for patients with the dapagliflozin arm. One, you already have seen that, but that is true that dapagliflozin across the whole ejection fraction spectrum was in beneficial position compared to placebo. That is true for cardiovascular death, for all-cause death, total heart failure hospitalizations, first hospitalization due to heart failure, cardiovascular death, MI, or stroke, and cardiovascular death or heart failure hospitalization. And one more study that probably was also mentioned today, but that's very, very important study, because we're always thinking that patients with, when we're prescribing patients, and mostly we're starting to do that, patients in a stable position, but what about the patients who are an acute heart failure or worsening heart failure? So this is very important to studies. And one study is EMPULSE, and another study is SOLAIST study. They were, so SOLAIST study had a not so nice, they stopped the study because of they entered the pandemic and they had some kind of problems, but still they showed the beneficial result of dapagliflozin compared to placebo in patients with a recent worsening of heart failure. The same was true for EMPULSE study that really showed that in patients hospitalized for acute heart failure, SGLT2 inhibitors, empagliflozin in this arm was beneficial compared to placebo. So, in my conclusion, and I really like that, and I really like that I do have time for discussion, due to the difficulties and due to very lots of challenges that we really have in heart failure with preserved ejection fraction, and due to their achievements and I would say revolutions that we really had recently, I think that my only conclusion is to be continued, because we really need and we're really waiting for different studies. One of them, they finished recruitment, and that was studied with sacubitril valsartan in patients with mildly reduced and preserved ejection fraction, and they would like to see how it works. Once again, they chosen active comparator, and another moment that probably it's also will be changed, because as I already mentioned, that FDA approved quality of life questionnaires as an endpoint for heart failure studies. And that is why it's true for heart failure with preserved ejection fractions, because in a stable situation, and I already mentioned about that, in stable patients, the mortality will be lower compared to patients with reduced ejection fractions. But it doesn't mean that we shouldn't just not taking them into account. And probably quality of life will be one of the major endpoints in patients with heart failure with preserved ejection fractions. So thank you very much for your attention.
Thank you very much for this elegant talk. And I ask about the device-directed therapy of this difficult issue of heart failure with preserved ejection fraction, because despite guideline-directed therapy, still the morbidity and the mortality is high. What's your opinion about the device directed therapy. Thank you.
About devices. So if we're saying about, ICDs, or we are saying about CRT devices, I'm not so sure that it's very relevant for heart failure with preserved ejection fraction, with one exception. If we are talking about hypertrophic cardiomyopathy or amyloidosis, when we see that a lot of ventricular arrhythmias, and including tachycardia, and well, it can be improved by CardioMEMS device, but actually that's still, these trials are ongoing. But CardioMEMS probably can improve not only, the whole spectrum, but also because they can be really very helpful in identifying of congestion, and that is one of the things. But I think it's probably another thing is about that mentioned yesterday about baroreflex therapy, because when they're doing that in to reduce the enlargement of atrium. So one of the kind of devices can be used in that field in HFpEF, but mostly devices are related to reduced ejection fraction.
Yeah, thank you for this great lecture. I think the most important topics for HFpEF is the diagnosis, as you mentioned. And what you, after your diagnosis for this patient, in your clinical practice, what you are doing for this patient?
Thank you very much. I think it's a very important question. And actually, one of the things that really probably will change my clinical practice, it's a DELIVER study. Because DELIVER study, what it showed that, well, we can use natriuretic peptides, right? So if we have patients with symptoms and signs, we understand that we just need to differentiate. Is it caused by heart failure, or it's a different cause of that? In that field, natriuretic peptides will make a great value. So if we really will see that natriuretic peptides elevated, so probably that is caused by cardiac reasons, right? And then I would really go for echo. But currently in my country, and actually my country may be not like an ideal example, we are doing echo sometimes before natriuretic peptides. But really, just it's very important that natriuretic peptides will make our life easier in identification of patients with HFpEF. Yeah.
Dr.
Anyone?
Yes.
Any question?
Dr. Amina, thank you for this elegant presentation. You are much welcomed in Egypt. I want to notify here that I had a visit for that new capital in Kazakhstan, Astana.
Yeah.
It is very, very nice, smart, well-organized city. I see there a lot of mosques, University of Nazarbayev, I think museum, big museum, one of them. So I should recommend that kind people, very, very kind people. My question about the clinical expertise for such a patient. Would you use ARNI still in this patient, or will you stick to the result of these studies in such a patient? Should know your expert in such condition, or only SGLT inhibitor is the true treatment?
Actually, that's a very tricky question. And well, if you were in Astana, in a very modern city, so you have to come to Almaty. It's a very old city, but still we're seeing that it's a very beautiful one. But according to your question, so according to our national guidelines, I can't use sacubitril valsartan in patients with heart failure with preserved ejection fractions unless it won't be in our guidelines. So I can understand that why FDA approved, because they've made a lot of, it's not only true for sacubitril valsartan, but also when investigators made a sub-analysis of our charm-preserved study, they also see that actually that was very good and that was very positive for patients below 60%, but above not so. So probably it's not only about a sacubitril valsartan, but it's about ejection fraction. So it was true for ejection fraction below 60%, but not above. And probably we really need to make a meta-analysis to see. Probably that will be also true across the whole studies with preserved ejection fraction. So in my opinion, I would be like to use, but I can't do that. And I have to go only according to guidelines. Guidelines of heart failure of EC, they are telling us that they're just RASI. And our national guidelines, the same. Absolutely.
Thank you.
Another question.
Thank you. I want to ask a question about the mechanism behind improvement in HFpEF by SGLT2 inhibitor, and also by SOTA, which is inhibitor of both SGLT1 and 2. What is the mechanism behind this improvement?
Well, that is a very nice question, but that's very difficult to answer because that is a very heterogeneous molecule, and actually it shows one of the reasons probably it's a diuretic effect, one of the reasons why. But if we could see just like their SGLT2 inhibitors, that was very good and with a good results in a NAFLD, non-fatty liver disease. They showed a good results. They showed a good results in a resistance of insulin resistance. So we have to make further investigations of this drug. But I mean, I can speculate a lot, but honestly, I won't answer you correctly and directly. One of that is probably diuretic mechanism.
Now, thank you, Professor Ejection, for this very elegant lecture.
Thank you.
And now we move to the next speaker. Professor Muhammad Hassan will give us a lecture about a very peculiar disease presenting by HFpEF, and which is oftenly missed as regards the diagnosis.
Bismillah ar-Rahman ar-Rahim. Good afternoon, everyone. As we know, cardiac amyloidosis is really commonly underdiagnosed in our clinical practice. And in my presentation, I'll try to highlight some clues and approach for diagnosis of such disease. So enthusiasm about cardiac amyloidosis has grown in the last years as a result of 3 areas of advancement and improvement. Firstly, observational studies showed that this disease is not uncommon as we thought previously. Actually, cardiac amyloidosis is present in near 13 to 17% of patients with HFpEF, and in around 16% of patients with aortic stenosis that undergo either surgical or percutaneous aortic intervention. Secondly, we have new imaging techniques that allow accurate, non-invasive diagnosis of cardiac amyloidosis, the ATTR type, without need for confirmatory endomyocardial biopsy and without need for taking a tissue biopsy for diagnosis. And thirdly, we have new therapies that are now approved for treatment of ATTR cardiomyopathy with significant improvement in survival and functional capacity. And importantly, these drugs are more effective when they are administered early during the course of disease rather than giving it late in more advanced stage. There are many types of cardiac amyloidosis. Actually, there are more than 30 proteins that can form amyloid fibrils and can deposit in the heart. But the two most important types are the AL amyloidosis and the ATTR type that account for 95% of all cardiac amyloidosis diagnosis. The AL, which is plasma cell dyscrasia, is due to the position of immunoglobulin light chains in the myocardium, commonly present at the age of 50 years or more, and it has a very poor prognosis. Once the heart is involved, the survival is near only 6 months. And ATTR cardiac amyloidosis type is due to the position of transthyretin, which is, as we know, it's a transfer protein for the transthyretin and for the thyroxine and retinol in the blood, and commonly also present in elderly patients 60 years or more, and the prognosis and the survival ranging between 2 and 5 years. There are two types for ATTR cardiac amyloidosis. There is a hereditary type, which is autosomal dominant and actually run in families, and there is a wild type. So when to suspect amyloidosis? Actually, there is some red flags and clues that alert you that this case could be amyloidosis. This disease needs a high index of suspicion, so you should actively rule it out in any case with some clues for this disease. These clues could be clinical clues or in the imaging or in the laboratory workup. The clinical clues, we know that the most important cardiac manifestations are the typical heart failure symptoms, just shortness of breath, dyspnea, lower limb edema, and this patient is intolerant and is not responding to our conventional heart failure treatments, especially also patients with persistent symptoms. The patient is still symptomatic despite aortic valve intervention, either surgical or percutaneously. This alert you that this left ventricular hypertrophy could be related to concomitant amyloidosis, not only due to aortic valve disease. The presence, we know AV conduction abnormalities is common in amyloidosis, so the patient can present with syncope or dizziness and also chest pain with normal coronary arteries. Importantly, there is some non-cardiac manifestations because amyloidosis is a multi-systemic infiltrative disease. So in the wild type of ATTR amyloidosis, there is some manifestations due to soft tissue infiltration like bilateral carpal tunnel syndrome, atraumatic rupture of biceps tendon, and lumbar spinal stenosis. And in the hereditary type, there is commonly to have peripheral neuropathy, autonomic dysfunction like orthostatic hypotension, postprandial diarrhea alternating with constipation, or urinary symptoms, urinary retention or incontinence, in addition to hepatomegaly and some ophthalmological manifestations like dry eye and conjunctivitis. There is important clues in the imaging, either in the ECG, echo, or MRI, that can increase the suspicion of having amyloidosis. Firstly, in the ECG, we know the presence of low voltage and discordance between the QRS voltage and the left ventricle wall thickness alert you for the diagnosis of amyloidosis, but actually this is present in nearly 40% of the patients. This means that 60% of cardiac amyloidosis has a normal voltage in the QRS. But pseudo-infarction type and pseudo-infarction type in the presence of pathological Q waves with poor R wave progression in the precordial leads and inferior leads is common in amyloidosis in near 70% of cases. And in up to 22% of patients, they have some sort of EV conduction abnormalities, either first degree or more advanced EV block. In echocardiography, the hallmark of cardiac amyloidosis is have left ventricular hypertrophy with increased LV wall thickness. There is some right ventricular hypertrophy, speckled granular appearance, but this actually not commonly seen in echocardiography. Thickening of the EV valves, and here in like case, thickening of the interatrial septum and the presence of pericardial effusion. All this some clues in the echo that this patient could have amyloidosis. Importantly, in the speckle tracking, there is a very sensitive and specific tool in the speckle tracking that, as we see here in this bowl, that the speckle and the strain, the longitudinal strain, is significantly reduced with sparing the apex. So apical sparing of the longitudinal strain is one of the findings in patients with cardiac amyloidosis. Cardiac MRI is helpful, especially to differentiate cardiac amyloidosis from other infiltrative cardiomyopathy or HCM with a characteristic diffuse subendocardial late gadolinium enhancement. So by the pattern of late gadolinium enhancement could help to differentiate amyloidosis from other infiltrative cardiomyopathy. In the laboratory marker, this patient has a heart failure, so they have elevated internal proBNP, and persistently there is a low-grade elevation of troponin. And actually, the biomarkers have much more prognostic value in cardiac amyloidosis. Here in the Mayo staging system, they use the troponin and N-terminal proBNP to predict survival of patients of cardiac amyloidosis, putting a value, actually it's a high value for N-terminal proBNP, which is 3,000, and 0.05 for the troponin. But if there are these two parameters are normal, so this predicts survival up to 66 months. But if there are two abnormal, this means that the survival is only 20 months. There is also UK staging system that use also N-terminal proBNP and GFR to predict survival in patients with ATTR cardiomyopathy. So we can summarize the clues, or what's called the red flags for amyloidosis in this word hidden. It's HFpEF. So we should suspect amyloidosis in HFpEF patients, typically over the age of 60 years, who are intolerant to the standard heart failure therapy. So the patient actually receiving the heart failure treatment and has some hypotension, or actually still symptomatic, with discordance between QRS voltage and LV wall thickness. Diagnosis of carpal tunnel syndrome and lumbar spinal stenosis alert you for this diagnosis. Echocardiographic evidence of increased LV wall thickness and the presence of peripheral neuropathy or significant autonomic neuropathy manifestations also alert you for this diagnosis. So if you have these clues or red flags for cardiac amyloidosis, what to do? There is still the presentation is suggestive of other infiltrative disease, so this in this stage CMR can help you in the differential diagnosis. But if not, the first step is to rule out AL amyloidosis by screening for monoclonal protein. Ask for blood and urine test, just the serum free light chain, the kappa lambda ratio, and serum and urine electrophoresis and immunofixation. So if the free light chain ratio less than 0.26 or more than 1.65, or if there is a monoclonal protein M spike in the electrophoresis, this has very high sensitivity, up to 99% in identifying AL amyloidosis. So if you have one or more abnormal urine or blood test for screening for monoclonal protein, so this patient should be referred for a hematologist to complete the workup, to do a biopsy to confirm the presence of AL amyloidosis, because this patient has very poor prognosis and need to receive a chemotherapy and other treatment. But if it's normal, so it depends if there is a bone scintigraphy available, and actually it's here, it's available. So bone scintigraphy is very helpful in the diagnosis. If not, you can go for invasive testing. But really, bone scintigraphy and nuclear scintigraphy with technetium pyrophosphate represent really a paradigm shift now in the diagnosis of ATTR cardiomyopathy. It has a very high sensitivity and specificity for diagnosing cardiac amyloidosis, the ATTR type. There are two ways for quantification, either semi-quantitative, just by visual comparison of the uptake of the heart to the rib uptake. If there is no uptake, so this is grade 0. If there is an uptake in the heart which is less than the rib uptake, so it's grade 1. Grade 2, there is an uptake. You can appreciate here that there is diffuse uptake of the tracer by the heart higher than the rib uptake, which is grade 2, and grade 3 if equal if there is more than the rib uptake, so is grade 3. And grade 2 and 3 are diagnostic for ATTR cardiomyopathy. There is another tool, which is a quantitative tool, just to compare the uptake of the heart to the contralateral lung. And if the ratio more than 1.5, so also it's diagnostic for ATTR cardiomyopathy. But importantly, you should know that there is some cases in which there of false positive bone scan, the bone scintigraphy could be positive in other cases other than ATTR cardiomyopathy. The AL type could be positive. So importantly, you should combine the bone scintigraphy with the urine and blood test, because if the urine and blood tests for monoclonal proteins are positive, so this case is AL amyloidosis. The second thing, prior myocardial infarction, if there is a scar in the heart, but this actually should be evident in the echo. If there is a scar, so actually it will take uptake and it lead to a false positive bone scan. The presence of significant calcification in chronic renal disease also can lead to a false positive scan. If there is an overlying rib fracture, the blood pool, and it's very important, once you have a positive bone scintigraphy, they do SPECT to differentiate whether the tracer was taken by the retained in the myocardium or in the blood pool. And also there is some unusual forms that lead to positive scan. Tissue biopsy actually is now only indicated if there is still high suspicion of amyloidosis with, for example, grade 0 or grade 1 bone scintigraphy, and if you have positive scan with actually positive serum and urine tests, so you need to differentiate, is it AL type or ATTR cardiomyopathy. So once you diagnose ATTR cardiomyopathy, genetic testing is essential. Actually, it's not having here. This is to know whether it's a hereditary type or it's wild type. Why? Because it's like HCM. It's an autosomal dominant, so which could be helpful in the screening of the family members if the patient has a gene mutation, if you found it in the relatives. So this patient needs close follow-up through the whole life. If you didn't find this mutation, so this patient does not need close follow-up, I mean the relatives. Once you have a confirmed ATTR amyloidosis, the treatment firstly is directed to the clinical presentation. If there is a heart failure, actually, unfortunately, this patient are not responding to the conventional heart failure treatment, but you give diuretics and heart transplant maybe in advanced stages. And in case of arrhythmia, a pacemaker and AV block, ICD in patients with aborted sudden cardiac death or VT. In atrial fibrillation, anticoagulation is recommended in all cases. But importantly, we have now some disease-modifying agents that actually approved for treatment of patients with amyloidosis, either to suppress the transthyretin by gene silencers like patisiran, so actually you decrease the synthesis actually of this protein, or TTR stabilization, just to stabilize this protein and preventing it from being misfolded and cause the amyloid fibril, which is the tafamidis, the famous one in cardiac amyloidosis, and the TTR disruption, so actually it revert the cardiac amyloidosis with some data still on for the use of monoclonal antibodies. We have now the data from tafamidis, which actually patients with ATTR amyloidosis randomized to tafamidis versus placebo, and it lead to significantly lower all-cause mortality and actually better functional capacity with significantly better 6-minute walk test for patients who are randomized to tafamidis. But importantly, this drug is effective specifically in class 1 and 2 and less effective in patients with class 3, when this underscores the importance of early diagnosis and early detection of these patients before going to advanced NIHA class 3 or 4, because tafamidis will not be effective in this subgroup of patients. So once you have involvement of the heart in cardiomyopathy, in amyloidosis, tafamidis now is approved for treating such patients in hereditary type with neural involvement. Actually, patisiran and the gene silencers are also approved for patients with neurological manifestations. So my take-home messages for you that cardiac amyloidosis, definitely it's significantly under-recognized and under-diagnosed in our clinical practice. Awareness of this, we will never diagnose cardiac amyloidosis unless we search for it. We should have high index of suspicion. You should ask yourself in any patient with HFpEF, this patient is having amyloidosis or not? So awareness of the red flag signs and symptoms can support the diagnosis. And now the bone scintigraphy combined with blood and urine tests can reliably diagnose ATTR cardiomyopathy without need for endomyocardial biopsy in most of cases. Thank you.
Thank you for this elegant presentation, dear Prof. Muhammad. And now, for the sake of time, we have to conclude this session. Thank you.